You guys hear me?
Okay, so thanks for having me. I am going to present really on an array of different technological options in the NICU. Just to give everybody an overview, we already heard from Dr. Smith a little bit about Angel Eye, but we're going to talk about sort of products that are on the market. And then maybe at the Q&A session, we'd love to hear what other units are using, what you all have found to be successful, and where are some of the challenges and barriers with integrating technology into our units. So I have zero affiliation with any of the described products. Aside from attending different presentations on them, I really don't have any personal or financial investment in them. So I wanted to talk about two real main ways that technology, at least to date, has been integrated for family engagement in the NICU. So the first is live stream video. There are really two major products on the market, Angel Eye and NICU. Baby Chat is a bit of a homegrown system that we've used at Children's Hospital that uses the video, that's video with a Y, sort of secure platform to use video, which is actually quite similar to FaceTime. But these are different options that include hardware and software from the companies to mount cameras at each individual infant's bedside. In talking to units across the country that have done this, some have a handful of cameras and they distribute them and use them for different families that might have a hard time coming to the NICU. Some have them in every single bedside. Some are using them all the time. Some are using them not that often. I think the experience is really varied. And so what data, if any, do we have on the impact of video? And so this is a study from the group in San Diego that really wanted to understand the impact of video on parental experience in the NICU. And so this was self-reported data, and they used a program called Family Link. And they actually found that families who were using Family Link during their infant's admission had sustained intention to breastfeed or provide breast milk at the time of discharge, and had an increased perceived parental perception in their infant's care. And so they found there to be sort of objective measures that families were potentially more likely to provide breast milk at the time of discharge and really felt more involved if they were interacting with their infant over video. And then second is a level 4 NICU. This is in Philadelphia at CHOP. They did a really nice quality improvement project and really wanted to assess the impact of parental stress with the use of their Angel Eye cameras that they use in their NICU. So they circulated the PSS NICU, which is a really commonly used parental stress score in the NICU at day 10 of hospitalization, and collected data regarding who was actually using their Angel Eye cameras in the NICU. And of their 48 respondents, about 44% of these families were using them at day 10 of hospitalization. Those who used the camera found that they reported lower levels of stress related to the sights and sounds in the NICU, the appearance of their infant, and their relationship within their infant and parental roles. So really kind of nice data showing, at least kind of real time at one snapshot during hospitalization, the impact of cameras on parental perceived stress and their experience. I wanted to highlight here just some local work. So there are likely others that I'm not intimately aware of, but Poudre Valley Hospital is using the NICU cameras as part of their family connectivity program. So that's new technology that they integrated. See some head nods from the PVH crew a couple of months ago. And then UCH here on the Anschutz campus is having families participate in CARES via video. So a little bit of a different application of video use in the NICU, not just sustained kind of live streaming, but actually having more of a dialogue and interaction with families during an infant's care time. So a couple of different sort of local examples of what's being used. And then second is really a different platform that really focuses on one-way text communication. And so there are two products that I'm aware of. One is Vocera Ease, and the Vocera product that many hospitals use as their communication devices and their phones. They actually rolled out this text messaging platform initially for their operating rooms, really to give families whose loved ones were in the OR sort of real-time updates about what was happening in the operating room. And they've then rolled that out to other platforms and other units in the hospitals, where it allows care providers, nurses, physicians, lactation consultants, therapists to send one-way text messages, videos, or photos to families. Most of these platforms also have group video conferencing, so thinking about integrating families into rounds through that app. And then they also, at least Angel Eye offers real-time surveying. So if there was opportunities to integrate research questions or family education, how's discharge planning going? What are you still missing? The benefit of these is they are HIPAA compliant, and so are sort of meant for hospital use. And then not only is there opportunities for communication, but a lot of emphasis on potential use of this technology for teaching. So imagine a therapist, demonstrating a certain position or a way of feeding the baby, kind of snapshotting that 30, 60-second video and then sending it to families. Most of these platforms have the capability of either having it be a little bit like, is it Snapchat where things go away? Sorry, I'm really showing my age. Or the ability to actually save the video so that they can watch it not only during the rest of the admission, but actually for a period of time after discharge. So talking about how do we give information to families and let them carry that with them so that when they walk out the door, their relationship with the NICU is. There isn't a lot of data on the impact of text messaging. This is a study from the United Kingdom, and it was a mixed method study. And they did it pre and post implementation of their video messaging service in their unit. I don't know which platform they used, but they really reported positive impact on family anxiety, sleep, family involvement, and relationships with staff. And then they had a really nice qualitative component. And a couple of things that I wanted to highlight here, you can read the comments as you wish, but really an enhanced emotional closeness with their infant, increased involvement in their care, even when they weren't at the bedside, and then positive experience and association with breast milk expression. In general, the staff for this study found that the platforms were pretty easy to use and didn't have a huge impact on their workload. So overall, there's a lot of pros and cons to technology, right? I think if it was easy, if it was cheap, we would likely all be using it, but there are some significant barriers I think that units face. So first is the capital investment. In general, the market is limited to a couple of companies, and it is a significant investment at the unit level for technology, especially technology that may require upgrading over. Second is security considerations. So I think families wanting to make sure, staff wanting to make sure that live streaming infants on a video platform is secure. And so how do we make sure that the platforms we're using are secure? Integration into other platforms. And so we're asking families to use more than one application. Many of our hospitals use MyChart through the Epic platform. There may be a milk tracking app that the unit uses or one that a family's using on their own. There may be other NICU educational apps. And so how do we make sure that things are centralized as they can be and we're not just asking families to add one more thing to their plate? I think a big one is expectations. And so what are the expectations that the unit sets with families around frequency of messaging or videos? That videos streaming might be turned off for cares or procedures. How do we sort of set that up appropriately at the get-go to make sure that that it's as smooth as possible? And then how do we disseminate and implement these technologies in an equitable way? And that's something that I know I struggle with. I think there's a lot of available technology, and I want to make sure that as we're implementing things in our own unit, that we're doing it in a way that we're not excluding families likely are already excluded. And so how do we make sure that we're not widening that gap, but really using technology to enhance and potentially narrow the gap for families that can't be. And then I know there are many healthcare providers in this room and on Zoom, and I think we have to be really conscious of staff workflow and staff burden, and that we're not asking, especially I feel for our bedside nurses, that we're not asking them to do one more. I think we want to make technology an enhancing part of their workflow and not another to-do list, another flow sheet, another box to check. So I think a lot of things to think about. Would love to hear later from you all how things have gone in your units, what you're doing, and maybe give us all some great ideas. that, I'll hand it to the next person.
Thank you. All right, next we'll hear from Shannon Brinker from St. Joe's. And I will highlight that St. Joe's is really the only NICU that I know of here in Colorado that really has integrated FICARE, or family integrated care, into their unit. And so we always learn so much from the St. Joe's unit.
Okay. Oop, yeah. Okay. Apparently I have a big R on the end of my name. So let's see. So we have worked on developing a education website for our hospital. And we did this about 5 years ago. We started this program or project, I guess, for a couple of reasons. One, we were doing all of our discharge teaching via a little cart that we had VCR and videos on, and we were rolling it around the unit from person to person to do discharge videos and CPR, that kind of thing. And it kind of got backlogged if we had multiple discharges in one day, and then there was a big infection component. So we were trying to figure out how we could best reach multiple people in a safe way. And then we also were working on implementing family integrated care into our unit. And so there was a lot of education we wanted families to be able to have. And I went to a conference, the Neonatal Therapy Association conference, where a gal from England had spoke and was talking about FICARE there and this great program they had. And they developed this really awesome app. And it was available for everyone. It's still available for everyone. But when we went and looked at it, it was really tailored towards the British community. So it talked a lot about nappies and different things that, and teats and things that we don't talk about. And so it just wasn't really going to work well for us. So we did our own website, and another nurse and myself got online and had never done this before, but developed through Wix.com, just a regular website, which our hospital was busy doing some other formatting of our hospital website, so they weren't able to help us. And then they will soon be taking over our website. But the way that Wix works is we can get in and edit it whenever we would like. So this is our website. Any of you can visit it. And this is kind of where we collaborated everything together. So whether it's family integrated care specific or just general information about our providers, there's pictures of providers on there. There's some, you can see there's some information about each gestational age, and in the smaller gestational age groups, there's information about our small baby team, so that parents can kind of go on and do some reading as they would like to. Like I mentioned, FICARE is kind of the focus on there. The balloons on the left, we recently in last year re-updated kind of our checklist, which is the balloons, and then each balloon correlates with one of the drop down items so that parents can really correlate easily which section they're going to, 3 things they need to do on there, and how that works. And then this is kind of, if they go into a section, say kangaroo care, then on the left there, you'll see kind of a list of what you'll learn. They can click on little lessons. The lessons pop up top right there. Each one looks, it's a version of a PowerPoint, and it's usually about 10 slides or so, giving people that version of a way to learn. And then there's with some things, like we have it for kangaroo care, for setting feeding pumps, bathing, a few other things that they're doing on their own that are a little bit higher risk. There's a little bit of a quiz and sign off to verify. So if Joint Commission comes, they can know that we know that our parents were checked off and educated in multiple ways. So that's how we use the website for family integrated care. And then we made our discharge is part of family integrated care, but we have our own little discharge section. And so this is where we put all of our VCR videos. And so some of them we re-upped and downloaded onto the website. Some of them we recreated. So we have our own personal discharge video. This is, I say one area we're lacking in our education is we don't have a lot of things in Spanish yet, but our videos are in Spanish. And then we're working on getting the education for family integrated care into Spanish as well. Our discharge survey is also linked on here. So we do a parent satisfaction survey on different things that we were doing. And so they go to this area to click on that link. And then we get all of our data that way, since we're not part of the big hospital data collection section. So that's there. And some of our videos are, like I said, kind of personally made. We have a videographer who helps us and makes little like commercials, I call them, that you'll see on there that have some of our staff in them. And then some of the stuff that's on there is something we've purchased, and we have that linked to a Vizio site, I believe it's called, with a password protection on it to kind of cover that we're not just putting other people's videos out there for everyone to see. And then, as was mentioned from the last talk, we wanted people to be able to access our information once they were home. So like the list of things on the right are a little bit more detailed, and people can go back and they're not required to do any of that to discharge the stuff on the left. They're required to do before they go home. So they can go back in, look at things that are related to discharge. They can go back and see any of the family integrated care stuff if they want to. And then this is an example of, on the left, the videos that we made ourselves that they can just click on right on the site, versus whether they're linked to something that was professionally made that's password protected. And because I'm an OT, I had to put in a little bit about some of the education that we're doing as well for our families, because we were having some trouble with discharge carryover as well from some of the teaching that we were doing. Either we couldn't meet with families one-on-one to do all of our play with babies, or they suddenly were eating everything and going home before we had time to work on that. And so families were feeling like there was a gap in between when we had them leaving our unit and working with us versus when early intervention was coming. And so we put some of the basic play activities. We have a section on massage as well that's not up here, but so if we can't meet with the families, they can go on and see the videos that way. Or if they're home and can't remember something, they can get back on and see those videos with babies that are their size, with oxygen and that kind of thing. So they're a little bit more realistic to kiddos that we work with. But questions are later, so.
Thanks so much. This just highlights why I love quality improvement. This is freely available to anyone who needs these resources. There is no reason for any NICU to reinvent the wheel and make any of this on their own. It is publicly available. Thank you, Shannon. Next, we'll have Tina Ramos share with us her qualitative work around family experience and use of technology in the NICU.
Great. So thanks so much for having me, and hopefully you can hear me okay. My name's Tina, and I'm a third-year neonatology fellow here at the Anschutz campus. And my research is really surrounding how we can improve provider-caregiver communication. And I'm excited to talk a little bit about the qualitative data that we have related to caregiver experience with technology. And I have no disclosures. So I know I'm talking to a group that is passionate about family engagement. So it's no surprise to any of us that family-centered care is important. And that's well published in the literature. Here is a model that shows kind of the 5 pillars of family-centered care. And the one that I want to highlight is information sharing. When we think about it, there is a significant exchange of information that happens every single day in the NICU among providers and nurses and caregivers, providers and caregivers, and even one caregiver to another. And so communication is really important. And I think understanding the caregiver experience with communication is also very important. And that's what prompted my research project, which I'll talk a little bit about today. So to quickly discuss the methods of my project, so I'm doing a mixed method study, which means that we're including different forms of data to kind of drive our interventions. So the first one that we're using is qualitative in-depth interviews to really understand the lived experience of caregivers in our NICU. We're then using the themes that we glean from these interviews to develop unit and system level interventions that we can then track over time with quantitative data. And so today I'll be focusing on the qualitative piece, which is really seeking to understand the specific aim listed here. And to do that, we developed a semi-structured interview guide, which means there are certain themes that we wanted to explore through these interviews. And we have questions and prompts to really understand what parents are going through in our NICU. And kind of the guide was set up to understand not only their experiences, but what has gone well with communication, what hasn't gone well with communication, what are the barriers to receiving timely and effective communication from providers and updates, and what are the general preferences for what sort of information families want to receive and from whom. And so I think a piece of this is, how does technology integrate in this? And so these are questions taken right from the interview guide, as understanding, are families even using technology like MyChart? And if so, what has their experience been with it? And so for those of you who may not be aware, MyChart is an app that caregivers can download on their personal device that gives them access to provider names and pictures, lab results, progress notes, upcoming appointments. And it's something that we wanted to understand better through these interviews. And I think the really cool thing about qualitative methods is that they're iterative. So after a first few interviews with families, I learned about this resource that I was completely unaware of called the Bedside app. And essentially, it's an app that lives on the iPad in all the patient rooms that has a lot of overlap with the information available to parents, but it also gives them the ability to see X-ray pictures and also vital sign trends. So once we learned about this, we thought it was important to ask not only about MyChart, but about this in subsequent interviews. So the results so far, we've done 15 interviews, and this here kind of breaks down some demographic information about the interviews we've completed. So 13 of the 15 interviews were done with mothers alone, and 2 out of 15 were done with mothers and fathers. You can see the majority of interviews were done in English, and those done in Spanish were done by interviewers whose primary language is Spanish. And in general, we had a wide range of gestational ages, primary diagnoses. Being a referral center here at the Anschutz campus, the majority of our participants did have outborn babies. And I just did want to highlight that the average length of stay that the interview was completed at was about 1 month in. And it became pretty clear after analyzing these interview transcripts that families are using technology, even more so than I was anticipating. And I have some quotes taken directly from interviews to kind of really drive this point home. So this mom commented on how much she loved MyChart for the ability that she could read the notes over and over and over again. So she thought it was helpful to have that resource and be able to reference it at any time. This mom also commented on how useful she found the notes, but also how helpful it was to have the names and pictures of her providers. And I think this highlights, we have many infants who have a lot of subspecialty care and a lot of people, a lot of cooks in the kitchen. And so she said that having the name and the pictures really is helpful. So it's not like she has to stare at the badge every time someone comes into the room. This parent also commented that they like seeing providers and they've really appreciated having access to their child's information. And again, kind of driving the point home that families can get updates from their providers and care team in the hospital, but this is also a way for families potentially who aren't able to be at the bedside to get updates. And I'll kind of close with that. So another part of this project was exploring, is there any disconnect that exists between the information that parents have at their fingertips with this technology and what's being told in the hospital? And I was also surprised to learn that in general, parents did not feel that there was a disconnect. Many commented that if they didn't understand a word in a progress note, they would Google it. And one parent actually found that it empowered her to ask questions about her infant's care. So she could reference the note and say, hey, look, I read this in your note. Can you please tell me more about that? On the flip side, there's so much information available on these apps. And one mother really highlighted how that can be overwhelming and anxiety provoking. And she acknowledged it's good to be transparent and share this information, but she kind of said, the more words I saw, the scarier it was for me, which I think is important to keep that in mind as we introduce this resource. I did think it was interesting, though, this was one interview that was done with a mother and father, and the father kind of chimed in at that point and said, I think the opposite. Like, I think it decreases my anxiety having this information. So I think it highlights that not every parent wants information in the same way. And it's important for us to understand each individual preference. It also has been really interesting to learn, now that we are doing more Spanish-speaking interviews, how the experience with technology has differed. And I think in general, the English-speaking families have been way more savvy with using these resources. And it makes me wonder, is this due to inequitable introduction of these resources, perhaps due to a language barrier? And also made me wonder, can this app be tailored to those who have a primary language other than English, so that they're having the same experience as our English-speaking families? And so this is one quote. A mom commented that she doesn't really use it much. She does have some adolescent kids who are way more on their phones, able to navigate that, but she just didn't know a lot about technology. And so this made me wonder, what sort of information is she missing out on that our other families who are more connected with this resource aren't? This is an exchange between a mom and an interviewer. She commented that the app is fine, and the interviewer asked, is it in English or Spanish? And she said it's in English. And for her, that wasn't a huge deal because they were able to translate it. But again, these families are having to go through one more step to get information that English-speaking parents don't have to. Another theme that emerged pretty evidently throughout all of the interviews was there wasn't a real standard timing of orientation to these resources. And these are some quotes to drive it home. So one parent commented that it wasn't really explained up front. And at one point it was just kind of shared, like, hey, you can actually get on this and use it. And I think this quote is kind of funny. One mom said, I just kind of found the iPad one day and I thought it was for games, but then I realized it wasn't. So in conclusion, I think parents in general have had a really positive experience with technology, and it's really not only furthered their understanding on the care that their infant is receiving, but I think is making them feel more engaged in their infant's care. It seems like both the MyChart and bedside apps are being used. And because of this, we really need to standardize our orientation to these resources, particularly for families with limited English proficiency. And I think there is still room to make it better. So potential next steps, I think it's important, again, to standardize how we introduce this to families and orient them so that every family has a level playing field and they're introduced at the same time in their infant's day and not, suddenly finding an iPad 4 weeks into their admission. I also think it would be interesting to explore what other resources we could put on the iPad. So could we put something that connects them to support groups, patient-friendly language about their infant's diagnosis that they can read if they want? So I think there's room that we can grow the resources that are available on the iPad. And then lastly, I think it would be interesting to see how we can use MyChart to better connect with families who can't be at the bedside every day, so that we can help them feel engaged in their infant's care even while they're at home. And this idea came from a parent who kind of commented that when you go to your primary care doctor's office or pediatricians for another child, she got an after visit summary that was kind of patient-friendly language about the summary of the visit. And she said that having something similar for her baby in the NICU would be really helpful, just a brief summary in layman's terms that she can reference at any time, like when she wakes up at 3 o'clock stressed about, having a baby away from her. And she also commented her husband is not able to visit. And so it's hard for her to relay information to her partner sometimes. And so having this layman summary would be helpful for that. And then I wanted to close with this. A mom was unable to be at her baby's bedside. They were moving, lived far away. And she said, I really wish I would have been more in touch with MyChart. So maybe reinforcing it is a great tool to stay in the loop when you're not physically here. And I imagine it's such a challenge for parents who aren't able to physically be at their baby's bedside, for them to feel engaged in their baby's care. And I think we're lucky to live in an age of technology and information sharing, where we could potentially bridge that physical distance between a hospitalized infant and their parents. So I'm excited to learn how we can equitably optimize this for families. I want to firstly thank the families who provided us with this rich information and their time, and my research mentors and team, many of whom are here. And I'm happy to answer questions at the end. Thank you.
Thank you so much, Tina. And last but not least, we'll have Allison Dempsey share with us her work with use of technology at the UCH NICU.
Hi there, I'm Allison Dempsey. I'm a psychologist and I direct our Connections program for high-risk infants and families in our Department of Psychiatry. We have a team of psychologists and trainees who are working in the UCH NICU. So we're going to be talking about exactly perfect segue that you just provided, how we can connect with families when they can't be at bedside and how we can promote family engagement using technology that way. So our team is engaged in a grant-funded quality improvement project to increase parental participation in care sessions in the NICU. So not just visitation at bedside, but being there in the NICU and taking care of the baby with the nurse, with the team. And we think this is important because, or we know there are several things that make this a useful experience. First of all, it relies on presence in the NICU. So the family has to be there or in some way to actually participate in cares. We have to set up a learning environment for the families. So we need to have, we need to use these as teaching sessions to teach the family about their infants. And then we also need a family-centered care model where we really view that the parents are the center of that model and that they are engaging in the care of their baby on a regular basis. And then that we're also thoughtful of the emotional well-being of the families as well, because when families are struggling, it is harder to participate in these cares and it is harder to be at bedside with their baby. So we used a typical model for QI improvement. So first ask, what are we trying to accomplish? How do we know if it's an improvement? What changes can we make? And then let's engage in some different trials to see how we can make iterative improvements in parental participation in cares. So starting with what are we trying to accomplish? We first looked at just how often parents were actually at bedside. And this was one of the hardest things for us to start was how do we determine what a good goal is for how often parents should be there and engaged in care? Because we've all been there where we feel we're like, oh, this family needs to take a break from the bedside. So 24/7 at the bedside can sometimes be problematic over a very long stretch of time if it's coming at the cost of self-care for the parent and family. And we also have, other barriers that prevent families from being at bedside. They have to work. They have to go home and take care of other kids, of other family members. They may live far away. They have house things they need to take care of. So really trying to land on a goal was hard to do. And so we ended up coming up with that our goal would be that parents will participate in cares, which take about 15 to 20 minutes, happen about 6 to 8 or more times a day. So we said just one of those care sessions, at least 4 different days per week. So more days than not, but that also allows plenty of time being away from bedside. And we didn't say it had to be one parent. We said it could be any parent, it could be any caregiver, just a family member who's there engaged with the baby. And we thought this is really important, again, because it's allowing for that education for the parents. It's allowing the parents to interact with their infant, to get to know their baby's needs, their baby's personality, and also allows for team and parent communications as well. So how do we know a change is going to be an improvement? So what's the return on investment for this work? So the hospital is very interested, of course, in length of stay and parental visitation. And so we looked at that from our data. We found that when families were meeting that goal after they had been in the NICU for 4 weeks, so those who were meeting that goal of participating in cares 4 days or not, or 4 days or more, had an average length of stay of about 80 days. And we excluded those who were about to be discharged within the next few weeks because we know they're going to be there more for more teaching and readiness to go home. However, those who were not meeting that goal at 4 weeks had an average length of stay of over 2 weeks longer, so 95.82 days. So that's a difference of 16 days between those two. And this is not evenly distributed across NICU families. We know that we see disparities in care related to this. So that top line is our commercially insured families in the NICU. And we see that they are on average able to be there at bedside over the course of the stay, ranging from about 70 to sometimes 100% on a given week during that stay. Those babies who are born to mothers who have Medicaid, that's how we determine the Medicaid status, already start out with more challenges to being at bedside to participate in cares, and those increase over time. So we see that the longer the baby is there, the less often they're able to be there at the bedside to participate in these care sessions. So we knew it was a problem. We knew we wanted to work on this. So we then thought, what change can we make that will result in an improvement? And so we grabbed what we thought was kind of low-hanging fruit, which is, well, maybe families don't have to be there at bedside. Maybe they can be there virtually. And so that's where our iPad project came in. So we knew there were going to be a range of challenges, and we learned this over our first few PDSA cycles. And how does this look? How do we get nurses or team members to set up the iPad so families can call in so that they can virtually participate in a care session? And as we ran through this project and talked with different individuals, got different feedback, we came up with this fishbone diagram of challenges. So, and it's too small on here, so I've got to see it up there. First of all, we need to make sure that patients are signed up for, we call it My Health Connection, same as my chart that was in the previous discussion. So we actually need to make sure that there's education for how parents sign up for this and that they're aware of this, because that's how we send them the link to be able to link to these sessions. How do we address language barriers to make sure that regardless that those instructions are in multiple languages for families? How do we make sure that the parents are able to coordinate with the nurses when is a good time to give cares so that they can sign on at the correct time? For nursing, we have a nursing shortage. We have travelers. It's a very hard job. We have higher acuity in our units. And so lack of time is a real barrier right now. Even something that adds 5 or 10 minutes takes away from their ability to care for multiple babies in the NICU. Lack of comfort with the idea of virtual cares. They're like, I'm not quite sure about this. And then often they had brought in ideas about, this is just like Angel Eyes. And they say with Angel Eyes, you're not supposed to do care sessions. You're supposed to turn off the camera during those times. And so giving education about this is not the same as a passive watching of the baby. It's an interactive session. Families are difficult to coordinate with. So cares in an ideal world would happen at a very specific time per day, and you could communicate that to the family and the family would hop on right away. That does not normally happen. Cares can get pushed back or need to start earlier, depending on what's happening in the NICU at a time. And trying to get a hold of the family and set up a time can also be very challenging. Perceived, should have changed this word, but entitlement of families is what kind of came up from some of our nurse interviews. But what really that meant is the families liked this and they wanted to keep doing it. So once they got this, they wanted this all the time. And the nurses felt really bad saying no to those families. And then they felt that the nurses sometimes felt like they had to leave the iPad on and kind of sit there with the families and with the baby and babysit them, which also wasn't a good use of their time. So as we got all this feedback, we kept iterating, and I'll talk about that in a minute. For psychology, we also found lack of time. It was hard to get everybody up to date on kind of the technical knowledge on how to connect to this. And then a burden on our nice postdoc over here who did this for probably our first 30 families all by herself. So it was a huge lift. For leadership, it was just some were like, well, are we supposed to do this? What kind of endorsement do we have from the leadership? And then where else was I on there? Sometimes just to get people invested in this, we had to say, well, Lanny's actually really invested in this project, or Dr. Barry's really invested to get the team on board with doing this. In terms of methods, we tried to collect surveys to get feedback. Sometimes that was a little challenging to get the surveys from the families, from the providers. And then we just found in the environment, for some reason, a lot of our chargers got misplaced. And so we could only find one charger and there were 6 iPads to charge. So these are just challenges we ran into in implementing this program. So hopefully if you do something like this, you can learn from these over time. But when we did start getting feedback from families, we actually found that it was a pretty positive feedback. So we sent them a very quick survey or had it translated into Spanish using an interpreter so they could respond. And 100% either agreed or strongly agreed to saying it was easy to connect to the call. The technical quality of the call was good. They were able to interact with their infant during the call. They could interact with their staff during the call. They all said they wouldn't have been able to participate in cares that day if they didn't have this. And then 83% said that they actually learned something new about their baby's care during these sessions. One parent said, I've gone through a couple health issues lately. If there was not a program like this one, I would have had to miss out on a couple days with my baby. It's amazing to be able to see her, even if I couldn't physically be there. And we also got relatively positive feedback from the nurses, and this was taken over the course of the project. And so I included some comments that showed that we received this feedback and we iterated in response to them. But at the end of the day, we had about 67% saying it was easy to connect to the call. 75% said the technical quality of the call was good. 92% said they were able to interact with the family, and 92% also felt that the family learned something about the baby's care. Some feedback we got is that it would be nice to keep these to 15 minutes and limit them to one time per day. So again, that idea of families really liking this and trying to put some guardrails around it. A therapist said I hadn't been able to meet the mom in person due to our schedule. So it was nice to be able to introduce us and explain what we do over video. Another said it was easy to use. They had no difficulty. The sound and the picture was fine. And they started doing this daily, having these virtual visits with the family and the baby. And then my favorite, of course, is this was a wonderful way to connect with a family that was not able to come interact due to transportation issues. It was great that we were able to have an interpreter on the video chat as well. I love that this is something we can offer our families that require interpreter services too. So our lessons learned thus far, we're still in this project, but once nurses start doing this, they often continue. So one of our hardest parts of this was figuring out how to get the nurses to connect to the call. We started out with a, what was it, like 6-page guide on how to do this. And it actually wasn't that hard. So we condensed it to one little card that's on there. So it's a lot easier to see like, oh, this isn't overwhelming, I can do this. It's important to have guidelines to communicate expectations with the family about this service. So this isn't Angel Eyes. We're not going to put you on and have you on for an hour with your baby. This is about the virtual care session. It's going to last about 10 or 15 minutes. If you're late, we may not be able to do it at this time. Families appreciated this and really liked that they were able to engage with their infant. More recently, we've also suggested a way, kind of going back to how to set the guidelines for what this looks like. So the nurse now signs on, engages and cares with the family. And then we have given the families a book, or they'll choose one from home. And so the nurse says, okay, it's time for baby to transition to sleep now. And so the nurse will leave, the family reads the book and signs off the iPad. And so it's a nice kind of way to wrap up the session. And as I said, easy to read and connection guides are really, really important. So wanted to acknowledge our psychology team who did a lot of heavy lifting for this, our research assistant who has pulled all these data from the flow sheet once a week, the nurses who participated and completed surveys, and of course the families who have participated as well. Sorry, shouldn't jump to that before questions.
Thank you so much. All right. Best part of this session, open discussion, question and answer for the panel.
So I have a question about with the cares, are you guys seeing more two-parent participation? And I'm a former NICU mom, and I know like in my experience, generally one of us was there and the other one was at work. And so are we engaging families in a way where now both parents are understanding more of their child's care? So kind of going back to that discharge starts at birth, right? And we're getting the parents ready, or is it still really one parent that's primarily involved in the technology with the cares?
Okay, this does work. It really varies on the family. I've actually been able to connect a father from his own hospital bed, and he was able to join the session, and mom was there in person, and we were able to connect dad. So that's been a way we've used it. We've been able to have both families at home or connect a parent who's at work, which has been really nice. Something that wasn't mentioned in this, but I think is really cool, is our NICU doesn't allow children under a certain age. And it's been a way to connect siblings, particularly young siblings who don't really have a comprehension of like their sibling exists in the world yet. It's their first time really seeing their sibling as a baby. And sometimes we've been able to get them to kind of participate in picking out what their favorite book is and having mom read that to both them and the baby, which has been really fun.
If we can repeat that question, it's what platform of software is being used?
Oh, I just have to hold it down. Okay. That is a great question. We initially had started with Teams because that was the HIPAA approved platform for this at UC Health, and we're able to transition to, it's the video or VidYO, people pronounce it differently, platform that's within Epic now, which is much easier.
Are any of these sessions able to be recorded really for, all of these technologies that have been highlighted? Are families allowed to record them for later viewing?
That's something that our nurses specifically requested to not be permitted. So our families sign kind of like a list of expectations, and that includes that they won't take videos during this. However, like some nurses have actually encouraged like, oh, if you would like to do this, like take some pictures of your phone so you know how to do this. So it's a little bit, we're saying no, but it's also up to the individual.
I'm just going to go again. Can this technology also be used for rounds? Like, I'm wondering, this happened a lot when I was there, right? Like I would kill myself to drive from Boulder all the way out to Aurora just so I could hear what was going on and we could kind of come up with a plan. And I'm wondering if that same technology could be used in rounds. And again, going back to that education and just like really, hammering home for the parents, like what the diagnoses are and how we can, start to think about what this might look long-term for your kid.
Yeah, we have, I think now 8 iPads, and they're all attached to lockable stands that are held in the central nursing office right now. And so I know our medical director is very interested in starting to use these on rounds as well. They're also available for people to take at any time, any of the staff to take at any time. So developmental therapists will sometimes take them and do sessions that way. The medical team are welcome to do that, to do counseling with a family or educational sessions with them. So they're used in a number of different ways. We just have focused for the QI project on using them for those cares in particular.
I'll also add that for the text messaging video platforms, there are hospitals that are using that one-way communication to give a quick snapshot of what was discussed on rounds. It's not quite the same as a two-way video conversation on rounds, but for families who aren't available either in person or for a phone call or a video conference at 10 o'clock on a Wednesday, just getting that the team was at the bedside, here's what was discussed, we'll answer questions later in the day. So I think there's different ways to do it depending on what a family might need and what their availability is. But I fully appreciate like families literally running into the room and saying like, please don't do me yet, I'm not ready. And I think there are ways that we can work around that. I will also say that for some of our longer term patients, this is really low tech, but we have a number of families right now in our unit where we actually just use our phone and we actually just call them. They answer the phone and we have our rounds with them on speakerphone. And is it quite the same as a full video conference? No, but I think getting to staff burden and workflow, if there's technology issues or things where it's difficult to connect or the family isn't ready yet, I think we have to come up with some compromises that doesn't impede the unit workflow. I think especially in the last year or so, I think most of our units can speak to having epic high census and acuity. And so ways that we can meet the family where they are and communicate without slowing the team down.
This is great, by the way. And I'm wondering, is it possible for families to have sessions in the evenings and on the weekends?
For us, yes, our psychologists all have one late night in the NICU. And so so that we can work with the night nurses. In fact, the night nurses we've found are much more willing to engage in this. It's a little bit less intense at night than it is during the day. And it's been more convenient for families too.
I'm going to ask a question a bit kind of on the dark side. So is there any concern that as this technology is more widespread, more widely adopted, that it takes the urgency and the attention away from families' tangible needs to actually get them to the bedside? So now we have an alternative way for families to quote unquote be engaged. Are hospitals then less likely to say, why should we cover transportation, food, address all these other needs when we have this technology now available?
I was thinking of possible feedback from staff that I've heard similar in the past of, well, now maybe we're against having the technology option because now families won't come because they can just engage in this manner. So sorry to throw the second part in there, but.
I think that's the importance of balancing measures with any quality improvement project, is that you actually are monitoring that. So that is something we're looking at to make sure we're not seeing a decline in parental presence. And we have not thus far. In fact, what we would hope is that being able to connect with baby actually improves that attachment with the infant, the communication and bonding with the team and feeling like they're part of the baby's care. And so that would enhance the likelihood that they'll start coming in.
I've also had families turn me down when I've called them because they're planning on coming in later that evening or day. And so they don't see the need to connect virtually if they're going to be there in person.
Yeah, sorry. I was just going to add a little bit. I mean, I feel like some provider bias right there when we really say technology is not going to be there, because the reality is every parent wants to be with their baby. And if we understand that baseline, this is just an adjunct that helps them connect when they have other children or they've got to go to work or their other thing. Because basically, I would say 99.9% of parents want to be in the NICU with their kid.
Can I add to that too? One of the things which we do is we have the Angel Eye video, which allows the parents to look at the video. But if you ask a parent, would they prefer to look at their child on video or see their child and live? I think that answer is the same answer for you when it comes to the technology.
Can I add one thing as well? I also think it behooves us as providers to help parents to understand when they are present why that's so powerful. So interventions like skin to skin, pointing out physiologically the change in the baby, noticing the baby's respiratory pattern, how you're feeling when you're holding the baby, that these sorts of interventions help to cement attachment. And then these other interventions are really an adjunct.
One interesting thing that we've been noticing in the data, and I think really started detecting the pattern more recently, is that we had seen a dip in families participating in cares, and we're thinking, what's going on? Are they not coming in? And there were several cases where the families are coming in regularly, but they're not participating in cares. And that also provides a really interesting opportunity to think about how much are we doing to try to engage the families when they're there? And are we talking about the importance of touching and interacting with the baby and setting up this learning environment too? When you're talking about, to the one-way text, what happens when a family has a question on the other end of that text message?
Yeah, I think my understanding is that at least with one of the platforms, the unit can choose to turn on the feature to make it dual way. It's similar to MyChart. There's a messaging system that most people use as the outpatient world, right? Like you can send your physician a message, they can write you back. We've talked a lot in our unit about turning that on the inpatient side. And I think it's really overwhelming to the team. I think it's overwhelming to have a sense of who owns that. And we change every 12 to 24 hours. So I'll be honest, we as a NICU here, we haven't yet broached that. But I do know that the technology definitely exists. I think it depends on how each unit is using the technology, if it's really meant to update parents and answer questions, or is it meant to send a picture and say, I finished my first bottle, tomorrow's bath time. Here's what I did with my therapist today. I think it really depends on what the goal of the messaging is for the unit and the families.
Question from the chat for Steph. Related to the MyChart app, could the use of the iPad and MyChart facilitate collection of data on race and ethnicity and social determinants of health?
Yes. Do we do that right now? No. So actually a plug for a national group that I'm involved with that is all level 4 NICUs across the country, that really is focused, piggybacking on a lot of Dr. Smith's work on discharge readiness and screening for social determinants of health. That group is very specifically interested in implementing that in a more standardized way. And right now there's a lot of discussion in that national group about how to do that. I think one of the concerns, if it's not done in person, is really couching the reason why the hospital needs to know this information, right? I think it's a lot different to have that in-person conversation with your provider or your bedside nurse or the social worker in the unit, to be able to then say, we have these resources available, than taking an anonymous survey online where you just feel like you're giving your information away and not sure what's going to happen with it. I'll also say, in terms of race ethnicity, that Children's Hospital here on the campus is really rethinking about how they're collecting that data and the language around how we're asking families for that data. So that's been a big sort of system-wide work and process that we found to be really lacking in our unit.
I'll just say, I think there's the obvious benefit for parents who can't be there. But speaking from my own personal experience, I was there every day of our 100+ NICU stay. And I spent one 24-hour period away from our kiddos, and it was very hard and to leave because I didn't have something like that. I didn't have a way to participate. I could call into the main number and get transferred to my nurse's phone, but that was my only way to have any idea what was going on, besides like maybe labs coming in on MyChart or whatever. But then there wasn't communication past just like the results that came in. So I think there is a huge added benefit to give permission or give parents permission to step away sometimes. Even if there's like potentially the dark side of that, I think that is also a good thing for parents' mental health. So I think that can be really good.
I just had a question about the MyChart use, and maybe this is for Tina. If you've thought about any ways to kind of standardize how the providers write notes. As you know, that varies quite widely now, and the accuracy of the information can vary, and how we can do better so that it could be a really great resource for families.
Yeah, that's a great question. And that was one surprising thing that came out of these interviews is, as a provider, I write notes and I had no idea how frequently families are reading them. They said, I read the note every day. And one parent even said, I saw on the exam that the provider said this, but, I was here all day and didn't see them come in. So I think like they're using notes and they're reading them. And so I think there's some room for systems levels way to make this aware, because I think a lot of providers know that since this act was passed, parents can read notes, but like me, they maybe were oblivious to how frequently it's happening. I think parents don't expect the progress notes to be in patient-friendly language. I think they understand it's part of the medical record and something that they're not expecting to be completely transformed into, a patient-friendly way for them to understand. But I think this adds to how we could maybe bolster it with that kind of one sentence summary in layman's terms. So maybe parents don't feel as obligated to read the progress notes and get bogged down by all that medical language. It's a great question though.
Bouncing off of that, have you seen that any of the patients maybe get anxious or overwhelmed or find maybe something out that a provider hasn't gotten a chance? We've certainly seen like brain bleeds getting posted and the provider hasn't even reviewed that yet and the parents are calling panicking.
Yeah, great question. And that was one major theme we wanted to explore with the disconnect between the app and what parents are reading and being told. And I think fortunately, by the time that we were conducting these interviews, providers had learned from those experiences to kind of set an expectation of if a baby was getting a brain MRI, telling them up front, like, this may come up on my chart at 11 o'clock with the final read. Please know that we will talk about it tomorrow with you, with the neurologist or brain doctors. So I think the providers have stepped up with, from a few kind of missteps with having that happen, to set expectations with the family, which I think helps to assuage some of that anxiety.
I was just going to say, I have mixed feelings about parents watching CARES because I am both a former NICU parent who would have loved that. And I'm also a current NICU nurse who can see some of the barriers to that. And so as I was reflecting on my mixed feelings, I was thinking, I wonder if as providers, and I don't know how many of us are nurses, but if we need to challenge, sort of the question that Susan brought up in the beginning of why are we here and why are we doing this work? And it's not just so that I can get my charting done and go home. It's to take care of families. And can we sort of change the idea of, well, that doesn't work with my workflow. And granted, we have acuity, we have census, that is something we do need to consider. But I wonder if we just sort of need to change our perspective of what our role is and maybe embrace more of the parent coach aspect of teaching parents how to engage and take care of their babies is our goal. And is one of our goals. And our other goal is, providing safe care and how do we marry those two. So just sort of thoughts.
Just to kind of add to that, what we heard a lot in the U unit where this is happening was the fear that parents were going to judge the nurse for how they were doing something and that they were going to see something or feel like one of the parents said, well, she was holding my baby like a sack of potatoes. And that was really jarring for the nurse to be like, no, this is your baby's fine. I know what I'm doing. And that wouldn't have necessarily happened in an in-person setting. And that was some of what the hesitancy was as well, is what if the parents don't like what I'm doing? Or what if there's a judgment there or they don't feel like I'm a good nurse? It was the interesting feedback side.
I think this discussion highlights how much work there is to do because clearly there is this big gap between providers and parents, that there's still this lack of trust that's been stirred up by the use of technology and the concerns that the medical team may have as technology becomes more widespread. And I can attest to those progress notes now being visible and families saying, I read those every day. And I'm thinking, oh my God, my notes are not great, and how we on the medical side think of it in almost a punitive way instead of just like Andrea said, how do we reframe it? Because if truly families are part of the team, if they are part of that circle, then we share information freely. There is nothing hidden. It's all about inclusion. And so I think this discussion was really fantastic in highlighting the gaps, but also where there are opportunities where we can make some tremendous inroads.